Hi everyone, I am Maulan Mahmoud. In this video, I'm going to share you a PBL talk show about rupture of the Achilles tendon. It is well known that many athletes' careers have been disrupted by ruptured Achilles tendons. So I'm going to give you a brief overview of Achilles tendon rupture. There is a legend from ancient Greece. Achilles is a demigod, half human hero who participated in the Trojan War in Homer's epic poem Iliad, and was also the first soldier of the Greek allied forces. He is the son of the sea goddess Thetis and the hero Peleus. After he was born, his mother Thetis turned his body upside down and immersed him in Styx water to make him a clean body, except for the heels that Thetis pinched. His entire body couldn't penetrate. Achilles killed Hector, the first warrior of Troy in Trojan War, turning the defeat of the Greek army into a victory. Later, the sun god Apollo led the little prince of Troy in Paris. The black arrow hit Achilles' heel, causing Achilles to be injured and killed. This is where the Achilles heels comes from. Okay, next, let's move to the clinical case. A male, 36 years old, professional basketball player. Chief complaint: after a rapid deceleration during a game, the right leg tendon was beating with noise. Plantar reflection was weak when walking. Then, the calf pain became severe and gradually worsened. He couldn't stand normally, come to the hospital for treatment timely. Examination findings: the patient is completely conscious and the vital parameters are within the normal range. There is a noticeable swelling of the distal third of the right leg during the examination, an indentation about 1 centimeter long, and the width of a palm could be felt above the calcaneus. The patient is unable to stand on tiptoe on the right leg. On examination, the ankle joint is normal. My presentation will focus on the following questions. What kind of examination should be used to confirm the diagnosis? What is the diagnosis of this patient? What is the cause of this type of disease? What are the clinical manifestations? How should the disease be treated and prevented? Workup test for diagnosis. The first one is Thompson test, also known as the calf squeeze test. It is an accurate means of detecting Achilles tendon ruptures. The patient is placed in a prone position with the knee flexed. While seconding the gastrocnemius, the clinician evaluates for the presence or absence of ankle plantar flexion. If ankle plantar flexion is absent, the test is said to be positive and indicative of Achilles tendon rupture. The second one is Medler's test, knee flexion test. The test is an additional physical examination finding utilized to assess Achilles tendon ruptures. The patient is placed in the prone position with the knees flexed at 90 degrees. If the injured foot falls in an increased dorsiflexed position instead of a resting plantar flexed position, when compared to the contralateral limb, the test of the injured limb is positive for Achilles tendon rupture. After MRI imaging, A. Shown is severe Achilles tendinopathy. B. Tendon fiber discontinuity with fluid-filled gap. C and D. Follow-up 18 months after casting show thinning and attenuation of the tendon, but re-established tendon fiber continuity. The ultrasound examination shows a rupture of the Achilles tendon. The gap between the two torn ends of the tendon is 8 millimeters wide. An X-ray image is lateral beam projection reveals no evidence of avulsion of a bone fragment at the attachment of the tendon onto the calcaneal tuberosity or of any fractures. So the diagnosis is right side Achilles tendon rupture. Ultrasound imaging may be used to assess Achilles tendinopathy and is considered by some the first-line imaging modality. Ultrasound provides clinicians with a practical means of evaluating Achilles tendinopathy and ruptures at bedside. MRI is often utilized to further evaluate Achilles tendinopathy, especially ruptures. Discontinuity of the Achilles tendon can be seen on T2 weighted image, where the signal in the tendon is increased at the area of rupture and the tendon diameter is increased. MRI provides greater anatomic detail as well as greater accuracy in detecting partial Achilles tendon tears. MRI has proved to be superior to ultrasound in defining ruptures histologically. Etiology or mechanism of injury. Indirect trauma is most often associated with Achilles tendon ruptures, which typically fall under three categories: mechanical, muscular, and poor tissue quality. The first one, mechanical, involves variations of a rapid loading process on an already tensed tendon, such as sudden dorsiflexion of the ankle with the knee extended while an eccentric load is applied. The second one is vascular, located 2 to 6 cm proximal to the Achilles tendon. Insertion is a known area of hypovascularity. The third one is poor tissue quality. Tendinitis, which is inflammation that occurs within the tendon after an acute injury. And tendinosis, which is degeneration process from repetitive tears related to chronic injuries, are known to weaken the tendon before it is ruptured. This often occurs in the form of repetitive microtrauma from improper training techniques. Clinical presentations. A classic presentation, a middle-aged male who participates in strenuous activities involving sudden pivoting on a foot or rapid deceleration as in recreational sports. A popping sensation of the tendon may be described by some patients, followed by an acute onset of severe pain in the calf and the lower leg. Patients who also attempt new strenuous activities without proper training and stretching or who typically lead sedentary lifestyle are more likely to experience Achilles tendinopathy, including ruptures. It is important to note that pain is not always an initial presenting symptom. Treatment. Conservative treatment is by plaster immobilization in full plantar flexion, followed by progressive immobilization up to the neutral position. Surgical repair may be necessary in the young, active patient and is followed by immobilization in plaster to reduce the risk of rupture. If surgical intervention is warranted, it should be done within 4 weeks of initial injury, although within 7 to 14 days of injury is ideal. Proper timing of surgical repair is imperative to post-surgical recovery. The inflammatory phase of wound healing occurs within the first 7 to 14 days following an acute Achilles tendon rupture. During this phase, vascularity to the injured tendon increases, aiding in post-operative healing. The primary goal of surgical treatment of Achilles tendon rupture is to reestablish appropriate tendon length and ankle plantar reflection. This is usually achieved when there is an end-to-end position of the damaged Achilles tendon. Several surgical techniques exist to repair the ruptured Achilles tendon, which includes percutaneous repair and Open operative techniques. Percutaneous repair has some advantages, including decreased operative times and decreased post-operative deep infections. However, it comes with the risk of increased sural nerve damage. After surgery, 10 to 12 weeks of immobilization followed by rehabilitation is recommended. Selection of the best treatment option is individualized with age, activity level, patient and surgeon interests, and experiences as guiding parameters. Peak incidence and risk factors. Predominant age is 30 to 55 years old. Risk factors. General risk factors include recreational athletes, stop and go sports, including basketball, tennis, and soccer. Pre-existing Achilles tendinopathy, increase in duration or intensity of running. Advanced age, male gender, and poor running mechanics. Fluoroquinolone antibiotics have been associated with Achilles tendon ruptures, with an incidence of 12 per 100,000. This is more likely to occur in first-time users of fluoroquinolone and usually occurs within the first 90 days of therapy. The last part is prevention. Physical therapy as well as physical rehabilitation protocol should be maintained following both operative and non-operative therapies. Eccentric and concentric exercise should be continued on a regular basis following Achilles tendon ruptures, and particularly before engaging in any vigorous exercise. The patient should reduce his or her training intensity during fluoroquinolone use and anabolic steroid use. This is the end of my presentation. If there are inadequacies, please criticize and correct. Give thanks to clinical key students and complete anatomy. Thank you. Thanks for listening and watching.